Welcome to our podcast, Practicing with Integrity, where we highlight the pioneering spirit of modern dentistry and offer a comprehensive view of the techniques and technologies at the forefront of dental science. Today's episode 4 is called Collaborating with Integrity, and my guest today is Dr. Aristides Ponticas, a periodontist in Phoenix, Arizona, the owner of Ponticas Implant and Periodontics. Dr. Ponticas is my first guest of the year and the first guest at our new studio. Originally from Texas City, Texas, you relocated with your beautiful wife, Debbie, your 2 twin boys. I guess they were born here.
They were.
In Phoenix?
Yes. Texas
City.
Yes.
Big petrochemical city, close to Houston.
Correct.
In the now Gulf of America?
Correct. Well, to be seen.
To be seen. Tell me about Texas City.
You know, a small Texas blue-collar town. My father immigrated from Greece in the late 60s, early 70s and settled there with his brothers and had small businesses and had an arranged marriage, brought my mother over, and they settled there, and I grew up there. It was a lovely, small Texas town. Idyllic upbringing. And go back and visit them often. They still live there and live very close to where they first had moved into an apartment so many years ago.
So that's where you find your favorite Greek food. Where do you find your favorite Greek cuisine here in Phoenix?
You know, I think Greek cuisine is best at home. And it's food that is very sentimental. It requires a lot of time, a lot of love. So I like it at home.
So we've known each other for about 5 or 6 years when we were introduced professionally through a mutual friend and colleague, Dr.
Yes.
Cesar Butura.
Correct.
We partnered together at a multi-specialty implant center, and we were working together, referring cases for single and multiple implants. And we'll talk about that a little bit later. But I want to go back to your kids. What keeps you busy nowadays with them at the age that they're at?
Sure. Yeah, I have 2 boys, twin boys. They're 13 now. I can't believe that. They are teenagers, and they are very avid basketball players. Okay. They love basketball. They love everything basketball. I always thought it was just the sneakers, but it's the sport too, and they're involved in their sports teams and their school team. So it's been busy to make it to games and practices, and I try to be present for everything.
That's exciting.
Yeah, it is exciting, and it's enjoyable.
That's super cool. All right, so from Texas to Pittsburgh.
Correct.
For your dental training.
Correct.
And then back to Texas for periodontics and your master's degree, homecoming. What were the highlights of your training at Baylor?
I think looking back on it now, it's actually more obvious what the real benefit was there. When you're there and you're in it, you're trying to survive. You're trying to learn everything. You're trying to be at your best. But as you look back on it, we were exposed to so many wonderful professionals there that are world leaders in their disciplines, and to learn from them, and now to know them and see them at meetings, and they remember you, and it's amazing. And then the Baylor family, now Texas A&M Health Science Center, but we still think of it as Mother Baylor. Mm-hmm. And the people we trained with who have gone on to be leaders in our industry and in different specialties, and to see them lecturing and to be so successful and to collaborate with them via text message and discuss cases is something I didn't know that would be such a great value add to the experience we had there.
It's an added family, right?
Absolutely. And I was so fortunate to have the privilege of going there.
Let's take a little bit of a step back, because it's important for some of the young listeners to understand. You're in dental school and you're at a point where you have to decide whether you want to stay in general practice or take a path into a specialty program. How easy was it to make that decision, and what drove you into perio?
Certainly. It was pretty easy because I didn't want to do either. I wanted to go to culinary school instead, but I couldn't tell my parents that. So I really had a very fortunate day where I was asked to help in the faculty clinic. And there's a wonderful program director there, and she was the head of undergraduate periodontics, and she asked me to come and help her. And we performed a connective tissue graft. I had never seen it before. I didn't know it was possible. And it was one of the most elegant, beautiful, soft procedures I'd ever seen. There was no drilling. There was no water. There was no...
Careful with the drilling.
No, there was no drilling. And it was like watching it in slow motion. And I remember watching her hands work, and I thought, this, I think I can do this. This is really beautiful. And she was very polite and kind, and she said, well, if you help me for the next 25 or 30 surgeries, I'll let you do a little bit of one. So I showed up faithfully, and from there, it just never changed.
Wow. That's incredible. Those are moments that you will never forget.
Never.
Career defining moments.
And even to today, when I sit down to perform some of these procedures, those memories are still very vivid. As I start to do it, it's almost like a warm blanket. It's almost comforting.
Mm-hmm. So 3-year residency program, right?
Yes.
And you're approaching the end of your residency program and ready to face a future professional life, making decisions. Were you ready to know where you wanted to practice? Was that a done deal, or what were the variables involved at that point?
At that point, I don't think that periodontics was as maybe sexy as a specialty as we like to believe it is today. And there really weren't that many opportunities. I knew that I wasn't ready to be on my own. Mm-hmm. So I took a job in a large group periodontal practice for a short period of time, which really gave me a wonderful introduction to not only private practice, but running a business.
In Dallas?
In Sacramento, actually.
Oh, in Sacramento.
In Sacramento, okay. California. And I was there from 2003 to 2007.
Okay.
And then 2007, as you mentioned earlier, I met my beautiful wife, Debbie, and came here to start a new life with her.
And what led you to Phoenix? Debbie?
Yeah.
Was she from here?
No, she had. We were both from Texas. We're both Texans, and she had taken a job here as a marketing executive for a large company, and we had just started dating, and one of us had to move. So I thought it was a good time for me to start something that I wanted to do and to do it my way.
And when you moved to Phoenix, which is a great city, I had moved here 5 years before you moved here. Did you move into a practice where you wanting to buy a practice? Did you come into as an associate or
Sure.
What were the decisions that you were making at that time?
I came here and I didn't know anyone and started to ask around, and a colleague of mine who I knew from Baylor was going to take some time off, and she offered up her practice, and I purchased it, and it happened very quickly. We discussed it, and then almost a few weeks later it was mine, and started working.
Turning on the button and just getting going.
And it was an interesting time because it was 2008 leading into 2009, which was learning under fire.
Of course. Yeah. You had to make it happen. You had to continue. You committed to buying a practice. It was the Great Depression at that time with all the housing crisis that we were living with, especially here in Phoenix. That was dramatic, yes. But you just pushed through. Keep going.
That is how we're supposed to do it.
You touched on something that was very important, and we've understood ourselves since the moment that we got to know each other, and I think we saw things, and we still see things very, very similarly. I went to dental school between 1987 and 1992, and periodontology at that time was very much about quadrant surgery. You're trying to rescue some very compromised teeth. There were surgical and non-surgical procedures, basically to rescue teeth, and scaling and root planing, some soft tissue grafting, not necessarily for a cosmetic purpose, but just to help people with their sensitivity and cover roots and try to prevent any further abrasion of roots. And now, 30 plus years later, as you mentioned, there's a lot of sexy procedures involved with periodontology. You've got cosmetic gum grafting, you've got dental implants, you've got hard tissue augmentation, soft tissue augmentation, sinus grafting, a lot of procedures, along with the involvement in oral medicine and management of antibiotics, and periodontology has changed a lot. Tell me how you've seen that in your practice since you bought it or since you started practicing.
Certainly. I think you stated that very well. And there have been wonderful changes. And I think it has gone from a specialty that was perhaps very scary for patients and maybe not very enticing for practitioners to something that an avenue where we can provide care, we can create health, but we can do it in a kinder way. We can do it in a way where the patient doesn't walk away from the experience and feel that they lost something, or maybe that more they gained something. And not only to preserve, but now to help replace and to help make things look better. With so much that we do as a specialist, a specialty generally has a more focused attention in one thing. But if you can accomplish all of these things, which I enjoy doing, it really makes for a wonderful practice, because you can perhaps see one patient here and do something resective, and then see someone over here an hour later and do something cosmetic. Mm-hmm. And it really makes for a wonderful experience. But there's so much there that, and as you know, we can have some of our specialists that are so keen on one part of it, and they're so gifted in one part of it that their practice is focused on, let's say, soft tissue augmentation. And they become great researchers, great people to publish their data to help us change our techniques and evolve our techniques. They're worldwide lecturers. And it's amazing to have a specialty where you can be subspecialized within or enjoy the gamut of what's available to help our patients.
And I think that's one of the other things that I've noticed that has changed. Before, kind of like for referral-based practices like yours and to a certain extent like mine, the referral would be very direct from a general dentist to a periodontist. But now you kind of see that there might be referrals within a periodontist to a periodontist, or from an oral surgeon to a periodontist, because the fields have become a bit more specialized. Have you seen that?
To some degree, yes, and particularly with soft tissue, because I think, to our good fortune, that is the one part of periodontics that truly remains really for us. Mm-hmm. Implants have become widely accepted in almost every dental specialty and in general dentistry. Even sinus augmentation, there are lots of techniques and courses for even the novice provider to perform minor sinus augmentation procedures. Bone grafting, it can be done at almost any level. But the management of the soft tissue really remains truly for us. And I think we're truly the best people for that. And we have the privilege to get to work with surgeon colleagues to help, and either preoperatively or pre-prosthetically or post to really help provide value to what they're doing, and to work together as opposed to against.
Always trying to achieve the patient's best outcome and favor their best interest in the result.
Well stated.
Well, I'm going to quote William Hazlitt, an English philosopher that lived between 1778 and 1830, because we're going to get into some topics that might create a little bit of controversy. When a thing ceases to be a matter of controversy, it ceases to be a matter of interest. So let's talk about some controversy so that we can maintain the interest.
Sure.
Is that good?
Absolutely.
All right. Let's talk about implant dentistry. So the trends in implant dentistry have changed dramatically. When we started working in implants, and I started in 1990, basically the work in implant dentistry was done from the bottom up, meaning from the bone up to the restoration. And I would need to build my prosthesis wherever the implants were placed. And there was no consideration for what the outcome of what that restoration would be. You just had to build it wherever the implants were placed. Then the trend towards the restorative-driven prosthesis was created, and then the bone had to be built up so that we could follow contours and create something that would be more aesthetically pleasing. Now there's a big trend towards not only restorative-driven, but sort of tissue driven. How do you see this pattern of changes, and how do you get involved in those patterns of changes?
Certainly. I think that as periodontists, we're always looked at as the kind of masters of this, and that we drive that. And that's really a compliment. But I have found recently, and more recently, that many of the people that I work with are very involved in wanting to know about that and want to bring it to my attention before I bring it to their attention. And I credit that to a lot of the continuing education and a lot of the learning everyone is doing and wanting the best outcome for their patient. So they're already putting it ahead of the implant and discussing what is the soft tissue going to be like? Do we have enough soft tissue? How can we augment this to be prepared for a great outcome? And conversely, if we can't, how can we start to discuss with the patient what the alternatives are going to be regarding whether it's pink porcelain or whatever we're going to need to do if we can't achieve the ideal, and it not be an excuse after, but a reason before. Mm-hmm. So it's actually really collaborative at this point, and I have the gift of getting to work with a lot of doctors very closely. And now, having been here for quite some time, we know each other's abilities, we know each other's sensitivities, and in that working collaboration has streamlined itself to work from the restoration and from the aesthetics down.
And part of that collaboration, of course, involves communication. And communication is only effective if it happens. How do you make sure that communication happens? And at the different stages, in the diagnostic phase, in the treatment planning phase, in the actual treatment of the patient, how do you communicate with your referrals? How do you communicate with your patients? And is it you directly? Is it your office team? And what are essentials of communication for you?
Certainly. I always wonder if I get annoying with this one particular thing, but it's this great tool called a cell phone. And it's just a wonderful way to immediately be able to touch with each other, having to call an office to ask if the doctor's there and wait and perhaps interrupt. I can take a picture of a radiograph and text it right away. I can, if I'm happy with an immediate post-surgical result, I'm well known for taking a photo with my phone and telling them, I'm going to text this to your doctor because I want them to see this right away. I have at least a dozen people in my favorites that we collaborate routinely. I can be at home cooking and I look at the phone, they're calling me, and we're going to have a conversation. I've had my children in the car as we're driving home from dinner and we're talking about something. So really, the cell phone has made it very easy to touch base with someone at any given time. I've answered my phone on a ski lift to talk about a patient. So that has been an really easy way to really connect immediately and share photographs, text a digital plan, ask for feedback on something. It's been great.
So you're very hands-on on that communication.
And I enjoy it.
With your referral.
Absolutely.
Yeah. And the communication with your patients. Of course, with a referral-based practice, what are those aspects of the communication that you are sensitive with so that you're delivering the information that is important for you to deliver and respectful of the information that the practice that referred you the patient needs to deliver?
Certainly. I've always prided myself on our consults, and I don't see this as a brief encounter. I want to always know that when I finish a consult and I ask, do you have any additional questions? I want to hear the patient say, no, you've answered everything. I'd just like to know when I can get started. And so perhaps if one were to review my schedule, they would see a significant amount of my day is spent in consults. And we've even had patients apologize for, I know I've taken up so much of your time. And I always reiterate, this is your time and this is what I'm here for. Mm-hmm. So I feel that amount of time really allows for the patient to get to know me, for me to get to know the patient. And you get to feel if that relationship is going to work well. And it's a two-way street. And you want to know that you can treat them well, and you want to know that they want to be cared for by you too.
Mm-hmm. Yeah, that's very important, so that there's that open communication. And as you mentioned a moment ago, there's no surprises, there's no excuses. It's matters that have been spoken about. Technological advancements that we have seen in the last 15 years have been advancements that we've adopted as practitioners, not as students. CBCT has certainly revolutionized the way we perform diagnosis and the way that we perform treatment, especially in implant dentistry. We can use it to diagnose a site for an implant, and it certainly becomes very helpful if we use this technology to use it for implant planning. Do you use it for implant planning? Do you fabricate surgical guides? Is that part of your arsenal when doing implant treatment? Are you a believer?
I am a believer.
Okay.
I anything that can be used to, again, enhance outcome, but also make our life easier. Of course, with the CBCT, you can do all sorts of digital planning on it, even as simple as take it and sit down with the patient and show them, allow me to put an implant into the site for you. And you can digitally put it into the site, and the patient will look at it and say, that's how my implant's going to look? Absolutely. And then, of course, transfer that information as well as an intraoral scan to the lab and do a full workup, restore the implants digitally, and then from there, fabricate the surgical guide. I have adopted surgical guides quite routinely for implant placement. Of course, there are some circumstances where perhaps a single tooth implant, not in the aesthetic zone, with adequate bone and soft tissue, we know we can provide a great outcome with this degree of experience. But with multiple implants in the aesthetic zone, want to have good path of draw for the restorative doctor, want the restorative doctor to have input in a complex case with either a single implant that's highly aesthetic or multiple implants. Easy to transfer the data from the lab to myself to the restorative doctor. Everyone can provide input and then move forward with it, everybody being confident and comfortable. Certainly makes the surgery a lot more efficient. Mm-hmm. Patients always say that was easy, and I say, no, it was efficient.
Correct.
But my caveat with it is I feel that it has become a little bit of either a crutch or maybe an easy way in for maybe the novice implant surgeon, and to say that, well, I have a surgical guide, I don't have to worry about this. Mm-hmm. And I will say that it's not always right. Mm-hmm. And you have to have the clinical acumen and the experience and the skill set to determine if it is going the right way. And if it's not, to have the ability to go without the guide and have to make whatever necessary changes there is. So I don't depend on it. I allow it to help guide me, but we have to remember that we have to perform the surgery.
That's where I was heading to. It's a guide.
It's a guide.
It's just not the definitive. Very good. Talking about dental implants, do you have a favorite dental implant, or do you have a few favorite dental implants? Yeah.
I've been a Straumann disciple since I was at Baylor, and that was instrumental in that. And there's a familiarity there and a very high success rate. And they have a wonderful product. There are many wonderful implant companies today. And I think it just comes down to your comfort. I will say I do miss the tissue level implant from Straumann. I have a large number of tissue level implants that I have followed for many years that do quite well. And of course the bone level was highly desirable, especially for the aesthetic zone. But I do miss the tissue level implant. I think it had really great bone and soft tissue qualities.
So it seems that essentials for you are sort of like a firm internal connection, like a solid, tactile, good sensitivity, that you're connecting your instruments well, good tissue positioning around the implants. Those are essentials for you.
Absolutely.
So the practices that refer to you, is that the main implant system that they prefer?
That has been, I believe Straumann has a strong hold in Arizona and in Phoenix. Mm-hmm. And it's been well received and quite successful.
Perfect. All right. That's very good. As we've gotten to know each other, we both know that we like to work hard, but we also like to play hard. So tell me about some of your hobbies.
my hobbies. Well, I've been a student of wine for many, many years, and you may or may not know that. I've taken some time to study for the SOM exams, and I've passed level 1 and level 2.
Wow.
Not really consider studying for 3, but it will happen at some point. But it's a wonderful subject. It's an international subject. Wine is something that's meant to be shared, so it's always neat to find other people who love wine and to share wine that you like or enjoy, and always something new to learn about it. It's a little bit like our field. You never can know everything and never can be the best at everything, so always learning from other people and always learning something new. I love to cook. Being Greek, the food is a part of our everyday passion, and so that has been an enjoyable hobby. And again, you're always learning something new and always trying something new, and easier to mess up in the kitchen than the operating room, for sure.
Of course. Do you and Debbie enjoy wines together? Is she also knowledgeable as you are?
You know, I'm ashamed to say that her palate's actually much better than mine, although she just doesn't really want to put academics to it. She just wants to enjoy it. And the more I try, the more I see that she's actually a little better than I am.
You know, she's very likely she's going to see this.
It's
okay. All right. Let's go back to our topic.
Sure.
Implant maintenance.
Yes.
It's a very common question that I'm asked by colleagues. And the most recent time I was asked this question, I was working out at the gym, strenuous workout, and a colleague saw me that I was just sweating it and asks me the question. I said, okay, this is going to be a long answer. Let me catch my breath, and then let's go at it. So let's talk about what your protocol is for the maintenance of dental implants. And I think this is a very important question. And let's break it apart in kind of like the 3 main categories of the maintenance of dental implants. Let's talk about first, single implants. What is that protocol? And let's talk about whether in that protocol you include the probing or not of those implant-supported restorations. And if there's a difference, if those restorations are or not screw retained, whether they're removable by the dentist or not removable by the dentist.
Well, a lot to unpack there.
There's a lot. Yeah. I know. Sorry.
So I'll subdivide it into the single tooth implant in the patient that presented for a single tooth replacement, but is periodontally stable, has no other significant periodontal issues, has a long-standing relationship with a dental office and a hygienist. It's a routine placement with good outcome. Generally, I return them to the regular maintenance schedule they had with their provider, and then I see them once a year for radiograph and exam to monitor the health of my implant. But I generally feel that this patient has the dental IQ and they are in a dental setting where they can be well maintained in an office that is also looking for the very same things that I am. We have the patient that perhaps has lost a tooth because of moderate to advanced periodontal disease, has other ongoing periodontal concerns. Those patients are generally shared between my office and the referring doctor's office or the restorative doctor's office for an alternating maintenance of some interval, whether it's 3 months, 4 months, 6 months. Because I feel because there are other periodontal considerations and I have concerns to maintain the remaining teeth, I like to keep the patient a little closer. Mm-hmm. As far as probing, I know that there's been a lot of discussion in the literature as to whether there's any value to it or not. As a clinician, I do want to feel the tissue. So the probing isn't necessarily so much for a number because the number can be very deceiving. And also probing can be very challenging around restorations that are either platform switched or maybe bulky. The probing isn't really going to be accurate, but it isn't so much for the number, but it is for a feel of what does the tissue feel like? Am I going to have some bleedings, or is there some inflammatory component? Is there going to be any suppuration? Is there something I need to be aware of? So it's more of a direct examination of the peri-implant tissues than it is for the traditional probing of, let's say, a tooth. Mm-hmm. So yes, I do probe, and it's not so much the number I'm looking for, it's more of the health of the tissue. Differences,
kind of like the consistency.
Absolutely.
Okay.
And even just to get feedback on the thickness of the tissue. Have I lost any of the value of the tissue? Do we need to be concerned about that? Hard to do that by just looking at it. From a screw retained or cemented, I would say that the majority of the restorations that return to me are screw retained. That is, I think, generally accepted. I like to see that. I know that says a lot about the placement of the implant. The very few that I get back that are cemented come from very specific doctors that I work with that have very particular protocols in their offices for cemented restorations. We have discussed it. We have had long conversations about it. Any restoration that's placed on any of our implants, we see them back after restoration for an immediate evaluation, of course, looking for some of those concerns. And if they're found, they're addressed usually immediately. So it's usually not a long-term issue. So really for me, I'm usually dealing with screw retained restorations and not that many cemented.
And any interest in removing any of those restorations on a periodic basis, yearly, every other year, or there really isn't any need for
on a
it?
single tooth restoration, I've not really seen any indication to do so. I think the really nice part is, should we develop an inflammatory component, then it is certainly easy to remove the restoration and have better access to the site.
When you're mentioning the compromised case in which you're sharing that patient because there's still periodontal disease and some remaining dentition, and sometimes you see that there's a periodontal breakdown, and you can either see two very different scenarios. So let's say an implant on a central incisor and a natural tooth on the other central incisor. There's times in which you see the bone and the tissue on the implant in perfect shape, and the bone and the tissue on the natural tooth completely destroyed, and you scratch your head. But there's also times in which you see the bone and the tissue on the implant completely destroyed. Is that peri-implantitis as a result of the periodontal disease on the neighboring tooth, or what's happening? What is peri-implantitis? How do we define this? This topic is really, as we're doing more implants, as more people are aging with implants, and implants have become such a common treatment modality for patients, and longevity of our patients is increasing, and patients are living longer with the implants we provide. We're seeing more of this. So what is your take? What is your management?
You provided two scenarios which are seen, somewhat routinely. And like you said, there are a number of implants being placed, and that number is growing. For peri-implant disease, I think the literature is pretty clear that the biggest drivers for it are an immediate history of smoking and a history of periodontal disease. So that's why I'm very cautious with our patients that have been treated for active disease and then rehabilitated with implants. Should we have breakdown, it does worry me that can, of course, affect our implants. So there is a strong biologic component to it. Certainly, we can look at implants that were maybe placed 15, 20 years ago, where maybe some of what we understand today about how we should be doing things perhaps wasn't maybe in vogue as much or in thought, or implants placed in different parts of the world that we see new patients that we're now correcting damage that maybe just happened a long time ago. Restorative issues with restorations that are perhaps challenging for the patient to clean, or they've perhaps not been taught how to clean it effectively. Interestingly, anatomical landmarks. I lately have seen many defects where implants are adjacent to a buccal shelf of bone or a lingual tori, and that odd anatomy of the bone creates a very unhygienic area for the implant and creates a bone defect. So a number of different avenues to develop the disease. And you're right, it's become a increasing new patient referral. It's not, I'm here for an implant, I'm here for you to fix my implant. Mm-hmm. And there's a lot there. It's a challenge.
How do you fix it?
I think I've been through the wave just like everyone else has. I mean, any implant meeting, I think they used to be termed the ailing, failing implant, and what do you do now? Mm-hmm. Highly attended, regardless of what time of day it is, everyone is there. And
Everybody's looking for the magic recipe.
Yeah, and then often lecturers would say, hey, look, I'm doing these 3 things. These work here. These worked here. I'm not really sure. And so we've gone through conservative treatment and the different kinds of scalars, more aggressive treatment with grinding the threads off and putting antibiotics back in there like in old periodontal surgeries, and grafting, not grafting, apically positioned tissues. And then today we're starting to see beautiful, elegant research coming from, I know we've spoken about Dr. George Kostakis from, I think, Rutgers University.
Correct.
And a fellow Greek dentist. Beautiful, elegant, smart research that is so conservative and really counter to what we've been trying to do all this time. I've seen him speak several times, and you walk away going, what were we doing? And so I'm interested to see how those protocols continue and if it is really the right thing for us to do. And they're very compelling with the results they're at least providing us now. Lasers have been a strong part of dentistry, and I'm implementing that as well in our surgical protocol. So that has a good track record, and I'm collecting data on it as we speak to see how it's going to help with these circumstances. But it is a challenge, and I can't say that it's always predictable. And there are so many variables. And of course, the aesthetic zone is going to be much more challenging than maybe a posterior molar.
Yeah, premolar or a molar area. Well, certainly a lot more work to do, a lot more to see, and hopefully there will be something that will come and become a bit more predictable to be able to help our patients with the management of this. Well, let's go back to the basics of periodontology. So many patients end up receiving dental implants because of the progression of periodontal disease. And a lot of times it's because the diagnosis of periodontal disease is not done properly, or it's not detected at the right time. How good are the current or the conventional diagnostic methods available?
I believe getting better and better.
Okay.
It's certainly a challenging diagnosis. In 2017, the AAP provided us a beautiful set of guidelines, a way of looking at it consistent with some of our medical colleagues that have to create some challenging diagnoses. So they gave us a new set of guidelines which has stages and grades to it. And it really is an elegant way to put down in writing what is intuitive to the experienced practitioner. When you see a patient that has, let's say, light or moderate bone loss, but heavy etiology, you know this is going to be a rather predictable situation to treat. You know this patient's going to do well if they go through with treatment. But let's say you see a young patient with advanced bone loss, but no etiology. They have regular cleanings, they've had orthodontic therapy, but they've lost a tremendous amount of bone. You know this is going to be a challenge. This is not going to be a normal case. So with this new system, it really helps everyone better understand what exactly does this mean and where are you on the scale of severity and progression. And I think it works really nicely. And I don't think it works only really nicely for the clinician, but I think it works well for the patient. And it's easier for us to show the patient and say, here's where you are. When you tell the patient on a scale of 1 to 10, what is your pain level? And they say 2, well, you know that's low. And if they say 9, you know that's advanced. When you can tell someone that you are at this stage and at this grade, and you can show them a visual representation, it is easier for them to understand this is serious, this is significant. No different than perhaps our colleagues, the oncologists, can convey maybe a difficult diagnosis for a patient. It is easier for us to help them better understand why they are seeing us and what we need to do. So I think it really works well.
And so you think that the indices used in clinical dentistry in that sense are useful?
I believe so.
With the way that they're being presented.
Absolutely. I think a lot of thought and a lot of experience has gone into this classification system. I think it works really nicely.
And how about the prognoses that are offered to the patients?
You know, I think the one thing that it doesn't take into account is the human factor. And I've always found prognosis to be highly tied to the patient's motivation. You know, we can have a patient that has a relatively straightforward scenario, and that can be easily remedied and perhaps not require much beyond that. But because of maybe a bad experience or a personal bias or maybe a cultural bias or financial constraint, they elect not to have treatment. And their prognosis, although from a scholastic point of view is good, it's not going to be long-term. And I'm faced, obviously, as a periodontist with many patients who come to us for a last resort, and they're motivated. They're motivated to give up smoking. They're motivated to establish better glycemic control. They're motivated to go through with treatment. And it may not be perfect, and we may not keep their teeth forever, but they can be successful beyond what maybe academically we think the prognosis is. So I do believe in what we do, and I think it really is in the patient's hands to really make it work for them.
Communication. We go back to that key element of treatment success. Let's go back to that procedure that kind of marked you and let you into periodontology. Tissue grafting, the connective tissue graft. You shared with me that it's one of the most sought procedures in your office, in kind of like cosmetic soft tissue grafting. Tell me about how that wave of procedures has come into your office and how it's changed the dynamic in your practice.
Certainly. Well, I find it really to be a very rewarding experience. So you really have my attention when we're doing something like this. And of course, you're providing some wonderful stability from a periodontal point of view, but then the cosmetic aspect of it has, particularly for a periodontist, immediate gratification for the patient as well. You know, not too much excitement for quadrant surgery to see that the gums have been apically positioned, but when you cover a root or create a nice outcome, of course, patients are very excited right away, and that's nice for us. The procedures have continued to change, and there's so many wonderful lecturers all over the world that are constantly changing our techniques and adding, and sometimes even going back. Dr. Pat Allen was one of my faculty at Baylor and is a world-renowned periodontist and very well known for his soft tissue grafting techniques. I had learned the fundamentals from him at Baylor, so that was a tremendous experience that I look back on, and it's a gratifying experience. And as we've said, a lot of the components that was particularly for oral surgery and periodontology, that has grown for everyone. Everyone enjoys doing implants and site development and bone grafting. So this one little niche has remained for us. And lucky for me, it's one of the things that brought me to perio. And of course, after 25 years of being able to perform these procedures, it's a warm place to be.
Nice. It seems like you're holding on to it really, really tight.
And I will enjoy it so long as I'm able to do it and provide a valued service for the people that we're fortunate enough that will come to see us.
And I love what you mentioned at the beginning. It gives you a warm blanket when you're performing these procedures because it puts you back to when you were a dental student.
Certainly, and looking for something to really gravitate to and to attach to. And I have great memories of that. And I've shared that with many, many patients over the years. They've heard the story. And it's a quiet moment in surgery, which sometimes surgery can be a little visceral or volatile. It's very quiet. It's very peaceful, and it's very enjoyable.
Let's talk about the last topic for today. Let's talk about the relationship between periodontists and dental laboratories.
Absolutely.
Of course, we're here because of Integrity Dental Services, a lab in which I'm the chief clinical officer. The dynamics of the work of specialists has changed. In the past, it was basically general dentists and prosthodontists that would be prescribing work to dental laboratories, orthodontists as well to a lesser extent. But now you see that there's more work that's coming. Tell me about how you've seen this change and how you've seen this dynamic in your practice.
I think there are a few key components to that. I think one is technology. You know, certainly from a surgical point of view, taking an alginate or any sort of impression in an analog form, not particularly exciting, messy, a lot of overhead to maintain the materials for that. Very easy to have a good assistant take a digital scan of something anywhere along the way. Very easy to transfer that information, something that's easily repeatable and reproducible. So certainly easier, and we're certainly happy to do something a little cleaner and a little easier. I think training programs have a lot to do with it because when I trained we weren't instructed on restorations. We just needed to learn how to place the implant. But now, as I understand it, most of the requirements for the training programs require the residents to have a certain number of restorations, immediate provisionalization. So it's been put in their hands a lot earlier, and it gets involved into their practice much easier. I think that's important. And then I think the mode of delivery of a lot of the procedures we're doing, historically, the surgeon placed the implant, the restoring doctor placed the restoration. But now we have many different offices that have multidisciplinary providers there. We have offices that have multiple surgeons that provide from diagnostic planning through restoration, and they're doing a lot of it themselves. The paradigm has changed and it's shifted, and I think that's not a bad thing. You can have a relationship between two doctors that are providing you care, and the patient may like that, or the patient wants to go to one place, have all of their services done, and have a very nice experience and a nice outcome. So I think there are a lot of factors that are driving that, and I think they're all very good.
Very good. Very interesting. Well, thank you, Ari, for this great conversation. It's certainly been a pleasure to have you here as my guest in our podcast. Delightful conversation, talk about periodontology, dental implants, wine, Greek cuisine, and quite a few other things. So thanks for being my guest.
It's been my privilege. Thank you.
Appreciate that. So with this, we conclude our 4th episode of our podcast, Practicing with Integrity. We look forward to more episodes of our podcast. You can follow us on Spotify, Apple, and other platforms. And until then, we'll see you at the next time. Thank you.